question of whether me watching episodes of Star Trek at 2 a.m. after my dog walks me up is the right way to manage my insomnia. Dr. Bowerfind.
Well, you stole my thunder, man. Yeah, I would save your applause. Make sure it's worth it. So I'd like to curse Jesse for inviting me to speak here today about insomnia. Let's see here. Disclosures, I have no financial relationships to disclose. We're going to talk a little bit about what normal sleep looks like. We'll talk about, obviously, insomnia and definitions. Talk a little bit about sleep diaries, an important tool in assessing patients with insomnia, but also other sleep disorders. And talk about the mainstay of insomnia therapy, which is cognitive behavioral therapy, and the several elements of that. We'll talk a little bit about alternative diagnoses and then finish up with some information about medications. So with the small amount of time that you have in primary care to see patients, I imagine that pulling the pin on the sleep grenade can be, if not terrifying, at least terribly time-consuming. And assessing and treating insomnia a lot of times is about asking the right questions and taking a lot of time with the patients. And for real insomnia patients, as a specialist, I take up to 80 minutes for a new patient to sit down and try to puzzle through what's going on with the patient. And it can take a lot of time to pull out the key elements that might underlie the problem. So my hope is to give you some strategies to employ with dealing with insomnia and to ease your way. When we think about normal sleep, we talk a lot about sleep drive. And here we talk about two processes. Process S, which is the homeostatic sleep drive, and that is the process by which adenosine builds up through the normal processes of metabolism. And it's adenosine that actually binds receptors on the cells in the basal forebrain that are essential for wakefulness and turns them off. And so throughout the day, adenosine is building up, and you can think of that as pressure to put you to sleep. And counteracting that is this process C, the circadian rhythm, which during the day is going to work to counteract that sleep pressure. But then towards evening, when we begin to secrete melatonin, the circadian rhythm will give way, and that pressure to put you to sleep will win the day. And you can see here the greatest urge to sleep occurs when there's the greatest distance between the homeostatic process S and the circadian rhythm. Now, the circadian rhythm is influenced by these zeitgebers. And zeitgebers are all of the things that help to set our schedule. So it might be the sunlight. It might be the meals that you're eating. It might be the television programs that you're watching. It might be the Daily Show, as well as sedating and activating medications that you might regularly take. So the light activates the pathways that communicate with the suprachiasmatic nucleus, which controls the timing of the sleep-wake cycle and promotes arousal, REM sleep, and sleep consolidation. And light entering the retina resets the oscillations of the suprachiasmatic nucleus. And these signals reach the pineal gland where melatonin is released in the evening when the light is diminished. That's when melatonin increases and begins to facilitate the processes of sleep. And this little chart down here is to remind us that all of our organs also have a circadian rhythm as well. And a lot of hormonal secretion takes place in a circadian way as well. So this is why when you're jet lagged or your circadian rhythms are off, you may be feeling nauseous, or you may be feeling in other ways disturbed other than just sleepy. So here we can see the effects of what happens to the process S, the homeostatic pressure, when we take a nap. So a nap will essentially bleed pressure off of this system and reduce the impulse to go to sleep later in the evening. So a nap early in the day relieves that pressure, and that distance between the process S and process C is diminished. Therefore, in the evening, that patient is going to be less sleepy and, at their usual bedtime. On the other hand, we can make use of this process S by employing strategies of sleep deprivation to increase that sleep pressure. In this case, maybe keeping the patient up all night long so that the next night they're more ready to go to sleep at the appropriate time. And it's important to explain to the patient that your body is only producing so much sleep right now if you have insomnia. And the amount of sleep you need is based on the sleep driver system. It's not based on the amount of sleep you desire. So you might want 8 hours, but right now your body's not doing that, and we have to play the cards we're dealt here. So I think it's often helpful also to discuss with the patient what normal sleep is, because many patients come in with misconceptions about how much they should be sleeping. Maybe their spouse sleeps 9 hours, and they are only sleeping 6 and thinking, oh, something must be wrong with me. But here we can see, this is from the National Sleep Foundation from 2016. These are the ranges of sleep at any stage in life. And you can see here in the adult years, it may be normal to only get 6 hours of sleep. On the other hand, it may be normal to require 10 hours of sleep. And so you need as much sleep as it takes for you to awaken feeling refreshed and ready to go. Sleep latency of 10 to 30 minutes is normal. So patients may be expecting to fall asleep right away. My head hits the pillow and I lay there for 20 minutes. I can't fall asleep. That's normal. So it's important to manage expectations. Less than 30 minutes of wakefulness after sleep onset. So again, it's normal to be awake a little bit during the night. Awakenings happen in everybody throughout the night. Most of the time we just roll over and go back to sleep, but up to 30 minutes is within the normal range. And it's also important to explain that there's going to be occasional bad nights. And actually, you can put a positive spin on that. A bad night's sleep tonight means that process S, that pressure is going to build up. You're going to have a much better sleep the next night. Bad nights happen to everybody. Not a big deal. So insomnia, one of the most prevalent complaints in primary care. Previously it was seen as a sleep disturbance secondary to a medical condition like psychiatric illness, depression, or other sleep disorder, or potentially medication, now also recognized as a primary sleep disorder. Short-term insomnia occurring in 30 to 50% of people at some point during their life, and chronic insomnia in up to 10% of patients. Twice as prevalent in women and increasing in prevalence as we get older, and tremendous direct costs, indirect costs of $100 billion a year in estimate. And unfortunately, the treatment is often limited to medication. And when we just give out medications to patients, the cognitive and behavioral factors and maybe the maladaptive behaviors in response to insomnia persist. Adverse outcomes associated with insomnia: decreased quality of life. Patients with insomnia have decrements in medical and emotional aspects of life that are similar to, in magnitude to patients with heart failure or depression. And nearly all patients are concerned that poor sleep has a negative consequence on their daytime function. Although most overestimate the magnitude of performance deficits, just as they tend to overestimate the magnitude of their sleep deficits. There is some decrement in cognitive function, though perhaps not as tremendous as many patients may suspect. And then there's a lot of self-medication that goes on. 1/4 of patients with insomnia use alcohol as a treatment, and it's a very common cause or pathway to addiction. There's increased suicide, largely mediated by comorbid depression and substance abuse. And then there's increased cardiovascular risk by activation of the sympathetic nervous system. There's a non-dipping heart rate with sleep that improves with treatment. Incidentally, it's also been shown that hypertension and diabetes, which can be worse in the presence of insomnia, can improve with treatment. What about mortality? There's a lot of studies showing different results with regard to mortality, but a large meta-analysis recently done here, Sleep Medicine Reviews in 2019, looked at 17 large studies and found no increase in mortality. So I think that that's a reasonable point to make to patients, and we have data to back it up. Patients come in fearful that, am I going to die from this insomnia? And I think it's helpful to tell them, no, you're not. Insomnia definition, so the International Classification of Sleep Disorders, 3rd edition, a complaint of trouble initiating sleep, maintaining sleep, or poor sleep quality. Some people throw in early morning awakenings to that as well. Importantly, not attributable to environmental circumstances or inadequate opportunity for sleep. And associated with daytime consequences, this is key. So patients who might be a short sleeper. There are some patients that only need 5-6 hours of sleep. They function fine during the day. They don't have insomnia. And lastly, not better explained by another sleep disorder. What about daytime consequences? So all of these sorts of things, fatigue, issues with concentration, attention, and memory, social or academic work dysfunction, irritability, and of course daytime sleepiness. Accidents, big thing to be concerned about. And then patients, another symptom might just be patients that are obsessively worrying about their sleep. So the ICSD 3rd edition simplified the terminology in insomnia to just short-term and chronic. So chronic is greater than, insomnia being present for greater than 3 months and at least 3 times per week for 3 months. We used to have all these other terms, primary, secondary, psychophysiological, idiopathic, and so forth. Thankfully, these were abandoned in the update. These terms were largely not reliably reproducible in clinical practice, and I think that's why they were abandoned. It certainly makes it a lot easier to communicate with patients and with other providers without using these confusing terms. So short-term insomnia, less than 1 month in duration, usually traceable to some acute change, be it a death in the family, a new job, new medication perhaps, but some inciting cause. Might be a new medical diagnosis. Severe insomnia with substantial distress. And what we want to do with acute insomnia is really reinforce good sleep habits and routine while they're working through that initial stress. This is where we can impact the progression to a more chronic state of insomnia. We want to help them maintain daytime function, control the escalating anxiety, and if necessary, short-term medication, maybe on the order of 2 to 4 weeks. Again, to help short-circuit this from evolving the maladaptive behaviors of chronic insomnia. And importantly, you want to bring that patient back in 2 to 4 weeks and make sure that they're making progress with that. So we talk a lot about predisposing, precipitating, and perpetuating factors of insomnia. And this was a construct or a paradigm that Arthur Spielman popularized back in 1987, where he said that there would be these predisposing factors, which might be an underlying medical condition that the patient has. And then precipitating factors, some event that came along to exacerbate and exceed the threshold to increase insomnia. And then as the patient's dealing with that, they begin to adapt other behaviors, whether it's drinking too much caffeine because of their daytime sleepiness, or doing things in the middle of the night that perpetuate their awakenings. And then they progress to this chronic insomnia, which becomes primarily due to those perpetuating factors. So predisposing factors might be, as we've already said, a medical disorder, pain, nocturia, shortness of breath, other sleep disorders. Big one is psychiatric disorders, so substance use. And substance use can be both a predisposing factor or commonly a precipitating and a perpetuating factor with insomnia. And there's often a bidirectional relationship here, sort of a chicken and egg. Which came first, the depression or the insomnia? And we often need to treat both. I think we often think about depression and insomnia as, well, if we just get their depression under control, the insomnia will go away. And often it does not. Same with substance use. And then trauma or PTSD can be targets for behavioral therapy. Perpetuating factors in the form of medications. So stimulants, obviously, largely mediated by the dose and the half-life. Steroids are another huge one here. Well, inhalers. So in pulmonary medicine, a lot of the inhalers, the albuterol, longer-acting beta agonists, less now, hopefully, theophylline, can be stimulants that cause insomnia. The hormones, prednisone, another one that we use a lot in pulmonary medicine, causes a tremendous amount of insomnia. Oral contraceptives is one we often don't think about. Antihypertensives, beta blockers can be commonly causing insomnia. And interestingly, there was a paper a couple years ago that looked at the fact that beta blockers actually downregulate or decrease the secretion of melatonin, and that the addition of melatonin in patients who have to be on a beta blocker, maybe for their cardiac disease, the addition of low doses of melatonin can help to attenuate that, especially in older patients. Alpha blockers, clonidine. Antidepressants is another big one. So again, we're giving antidepressants to patients who may manifest part of their depression with insomnia. And it turns out that SSRIs, SNRIs are associated with insomnia in about 20% of patients. Morning dosing is recommended in those cases, but it's not clear that that actually reduces the risk in those 20% of people. So you might think, well, that's a good strategy, but the insomnia may persist. And it may be the medication. So at some point, you got to consider maybe it's not just the insomnia. And then opioids, another big one. So we think, well, opioids are sedating, but that can cause problems with comorbid diseases like obstructive sleep apnea or central sleep apnea. That can lead to worsening disruptions of sleep and worsening insomnia. So these perpetuating factors then are behavioral and cognitive compensatory responses to sleeplessness, poor sleep habits. They get in the habit of napping and dozing, which reduces that sleep pressure, making it harder to fall asleep that night. Unrealistic expectations of sleep and increased anxiety all contribute to these perpetuating factors. So I'm not going to go through all the details of how to take a sleep history, but we want to get these sort of details from patients. And the duration of symptoms, again, referring back to, well, when did this all start? And try to figure out, was there some inciting event? We want to know a lot about their sleep times per 24 hours. So patients will talk a lot about how little they slept at night, but they won't tell you that they took 2 3-hour naps that day. So you got to be specific about how much sleep are they getting in a 24-hour period. And then also, patients will be more likely to talk about that one bad night they had last week and not the multiple decent nights that they had. And then these sorts of things. What do you do if you have trouble falling asleep? Are you using a sleep aid? What about sleep-disordered breathing? Are there things like obstructive sleep apnea underlying this that we ought to be looking at? Restless legs, and then the timing and dosing of caffeine and alcohol. Patients will tend to catastrophize a little bit about their sleep. So when you ask them a little bit about sleep history, you'll get a lot about, well, last night I hardly slept at all, or I try to go to bed around 9 o'clock every night. And then you got to follow that up with, well, but I went to bed actually around midnight. And so patients will tell you, I try to go to bed at I try to wake up at 6 o'clock every morning rather, but I usually hit the snooze alarm for 2 hours and get out of bed 2 hours later. So you got to know the specifics. And what will help with that is a sleep diary. And I'm a big fan of sleep diaries in getting that history from patients. So A tip for you all might be, if you start getting the idea that the patient's struggling with insomnia, is at the end of that visit perhaps hand them a sleep diary, get them to fill this out, bring it back at the next visit, and we'll talk more about this then when you can get some more details. This will help to avoid recall errors. You want to get at least a 2-week sleep diary. And importantly, an important direction is to fill out each morning within 20 minutes of getting out of bed, or their final awakening if known. In truth, I'm lucky if they're filling it out 20 minutes before their appointment, or filling it out while I'm sitting there in the room with them. But really, if you can, you got to specify this, that they fill it out each day to avoid those recall errors. And you might want to ask about scheduled disruptions. So you don't want to hand them the sleep diary and then have them go off on vacation and, or something, and they come back with it filled out and they say, but this really doesn't represent what I usually do. And then you can use these to monitor therapy and follow up. And then which one? There's a variety of sleep diaries available out there. I tend to like this one. There are a lot that have a lot of detailed information that patients can fill out. And you get a lot of good information from those, but they're really hard to look at and to get a good sense of all of what's going on over the course of a couple of weeks in a patient's sleep. So there are directions up here, and this is an example here of one line of this. So the patient worked this day. The E here says that they exercise between 1 and 2, and you can see here that the sleep time is in the middle here. So midnight is actually in the middle here, not off to one end or the other, so that the usual sleep time is in the middle of the chart. Here the patient had some alcohol between 6 and 7. They took a nap here from 7 to 8, and then at 10:30 they got into bed, but they didn't fall asleep for an hour and a half. And then they felt like they slept for 4 hours. They laid awake in bed for an hour before getting another 2 hours, and then having some caffeine and taking their medication. I add to this my own additions here, which are number 1, complete this within 20 minutes of final awakening. And I like to put arrows on here to show that this patient actually got into bed here, or laid down here, got up here, they got into bed here, and this tells me that when they leave this gap here that they actually didn't get out of bed, right? So they're just laying there then. If they had gotten out of bed, I'd ask them to put arrows there to suggest that. There's not a lot of room here for a lot of other data, and some of your obsessive insomniacs will come with this and then a 12-page addendum to it where they write down all their other details. So you very quickly, this person was able to maybe only keep with it for 4 days, but you get a good insight that they're taking a lot of naps here. They're probably drinking a little too much alcohol here. And they're laying in bed here a lot of the time without sleeping. And you can get that sense just from a quick glance at this diary. This patient is going to sleep and getting up at all sorts of different times. And I'll tell this patient, look, you're effectively jet lagging yourself. You're going to bed in London here and waking up in LA and back and forth you go across the country. It's not surprising that you feel terrible. You're consistently suffering that jet lag. So insomnia is caused by all of these different mechanisms: reduced sleep drive, disrupted circadian rhythm, and then those cognitive and psychological arousal issues, anxiety, racing mind, obsessional thoughts, concerns about their sleep, and all these maladaptive behavior. We often, get to talking about what's their underlying medical condition while the patient is sitting there worried about all sorts of other things while they're lying awake at night. We're focusing on that one problem. They're worrying about their finances, their other health issues, their mortality, what's going to happen with their family, and so forth. So, cognitive behavioral therapy. This is the first-line treatment for insomnia. It's denoted to be so by every major medical association. It's effective. So up to 80% of patients benefit from cognitive behavioral therapy. 50% will achieve clinical remission. It's shown time and again to be superior to sleeping pills. And there's no significant adverse side effects. It's been demonstrated to improve all of the different qualities or markers of sleep. And there's been documented continued improvement as patients continue to adopt cognitive behavioral therapy and perfect it. Improvement in sleep over time up to 1 year and lasting for at least 3 years. Now, that was the duration of that study, but probably even much longer than that. What does it look like? Well, CBT-i is commonly, we think of that as being in the domain of a cognitive behavioral therapist. Formal training or formal therapy with a therapist might include about 5 to 8 sessions where they go over some of the things that we're going over here today. So an initial assessment with sleep education and a review of sleep diaries that they adjust weekly. Education on sleep hygiene and stimulus control, sleep restriction, relaxation, cognitive therapy, and then relapse management. The problem with this is there's a scarcity of providers that can do this. It takes an awful lot of time for the patient, and it can be extraordinarily expensive. So we'll talk about some alternatives to that. So what about sleep hygiene? Well, this is something that most of us do. We'll hand out a pamphlet here, follow these rules. There's no studies comparing sleep hygiene to sham therapy or to no intervention. Although it has been used as a control arm in multiple studies, and it has been shown consistently to be of benefit, it is not supported for use as monotherapy. And all too often, with regard to cognitive therapy, this is about the extent of what patients get. Here, this pamphlet, which might say a lot of these sorts of things. So these are some of the fundamentals of sleep hygiene. Sleep only as much as you need to feel rested and then get out of bed. Keep a regular sleep schedule, right? So how many of us tell our patients, go to bed and wake up at the same time every night? That's good recommendation up to a point, but we have to be more directed. We have to be a little bit more specific than that. I would say go to bed, but not before a certain time, but only go to bed if you feel sleepy. So don't go to bed just because it's 9 o'clock. Go to bed because it's at least 9 o'clock and you're sleepy, or wait until you feel sleepy. So that's to keep patients from going to bed at a regular time and just laying there awake. Don't go to bed unless you're sleepy. So don't force sleep. The bedroom should be dark, quiet, comfortable temperature. And patients often have adapted a lot of different behaviors that break this rule, right? So number one, they might have a disruptive snoring sleep partner. A lot of patients, you got to ask about pets. They'll have pets crawling all over them and asking to be let out in the middle of the night. They will have a lot of light-emitting screens that they're using throughout the night. So no light-emitting screens either in the hour before bed or during the hours of sleep. So much of the time, if you start asking patients about this, they are checking their phone in the middle of the night. And we see this all the time, even in the sleep lab. Their phones are going off. They're waking up, checking texts in the middle of the night in the sleep lab. Eventually, the tech will go in and gently offer to remove the phone from the bedroom. But it's unbelievable, the stuff you see. And this is huge now. This is a much bigger problem than it was when I first started 15 years ago. With the ready availability of all these tablets. So I recommend that they turn the house down, dim the lights by half, at least in the hour before bed. Address worries before bed. Maybe have a notebook beside the bed to jot down sort of things that they're worried about needing to address the next day. Caffeine and alcohol we'll talk about in a second. No smoking, especially in the evening. And now you got to even be more specific about that, right? Because you'll ask people, do you smoke? No, but it turns out they're juuling or whatever else, right? So they don't think about that as smoking now. And yet it's huge amounts of nicotine, a very stimulating medication. And because they don't need to get out of bed to go out and smoke now, they can just reach over when they wake up in the middle of the night and do their vaping and try to go back to sleep, or in most cases not go back to sleep because of the nicotine. Don't go to bed hungry. A light snack, maybe a protein-based snack is helpful to prevent hunger in the middle of the night. And exercise regularly, at least 20 minutes. A lot of studies have shown that vigorous exercise is counterproductive, but moderate exercise, at least 20 minutes, and not right before bed, so at least 4 to 5 hours before bed. One thing about the TV, so a lot of patients say, well, you got to ask about the TV. Do you leave the TV? Oh, I have to have the TV on because the white noise, it helps me. But in fact, when these patients are having their normal awakenings that everybody has in the middle of the night, they're opening up their eyes, that bright light is flashing on the ceiling, somebody's ranting on the TV, and they're locking into that, and it perpetuates those awakenings. So just because you've always needed it doesn't mean you really need it. Let's do the experiment, and I say this a lot to patients, let's do the experiment of just turning off the TV for the next month. Or let's do without the caffeine. Avoid clock watching. This is a big one. So you can talk to patients about this, and a lot of them are doing this, right? So again, just like the TV, this will prolong awakenings. And I actually show a lot of patients this hypnogram. This is a hypnogram with the time of day here, the stages of sleep here, and showing that we start off with wakefulness here, we get into the deeper stages of sleep in that first hour, and then we often have an awakening. That's normal. And this is actually a normal hypnogram of a normal adult male. And all of these times that this line is touching wakefulness up here, they're having a brief awakening. We all do this, but most of the time we wake up and we roll over and we go right back to sleep. These patients are conditioning themselves to look over at the clock. What time is it? Oh man, it's only 2. I've only been asleep for 2 hours and I've got to give grand rounds tomorrow and I'm going to be awake all night. And it starts off this rumination. So I tell patients, set your alarm, turn the clock away, better yet across the room, set it and forget it. Caffeine in sleep. So caffeine is similar in structure to adenosine and blocks the effect of it. Remember, adenosine is that thing that we need to build up that puts us to sleep. Has a half-life of 6 hours. So there was this study where they looked at 200 milligrams, a cup and a half of coffee at 7 o'clock in the morning, detectable blood levels at 11 p.m. And affected on polysomnogram, it delayed sleep onset, decreased total sleep time, reduced sleep efficiency, and sleep continuity. So if it's doing that at 7 o'clock in the morning, what's it doing with your 3 p.m. or your 5 p.m. cup of coffee? Audience participation time. All right? So here we have 4 choices of different drinks. We got your Monster Energy 16-ounce Mountain Dew Red Bull or an 8-ounce Starbucks. So everybody votes once. So who votes for Monster Energy as having the most caffeine here? All right. What about Mountain Dew? Yeah. Oh, this is a smart audience. Red Bull. And what about coffee? This is an 8-ounce coffee. All right. So Mountain Dew has 54 milligrams, about 4.5 milligrams per ounce. Red Bull has 80. Monster Energy has 160. This is an 8-ounce cup of coffee. You cannot buy this unless you ask. This is not on the menu. Okay, 180 milligrams of caffeine in a Pikes Peak Starbucks coffee. Again, not on the menu this small. So your Venti is going to have over 450 milligrams of caffeine. The recommended dose is 200. Okay? So keep that in mind. Effects of alcohol. So this says, I found my sleep number, and it's 7. 7 beers. So alcohol can affect sleep tremendously. So in the first half of the night, so a lot of patients are using alcohol. As I said, 20 to 25% of patients with insomnia are using alcohol to facilitate sleep. Allows healthy people to fall asleep quicker, increases slow wave sleep for a while, and reduces REM sleep. And in the second half of the night, it causes very shallow sleep with a lot of fragmentation and increased awakenings. And it ends up reducing total sleep time. So alcohol can affect the homeostatic sleep drive and causes shift in the sleep cycle, and then this destroys their sleep. And insomnia can lead to alcoholism. Alcoholism, on the other hand, can lead to insomnia. And the prevalence of insomnia during active drinking ranges from about 60 to 90% of patients. And then there's, as we all know from hospital work, there is severe insomnia during alcohol withdrawal. Alcohol can also worsen snoring and sleep apnea. It's a potent diuretic, so patients are going to have to get up and pee in the middle of the night. That also goes for caffeine, right? So both of these will have patients waking up more in the middle of the night. Worsens reflux, increases the likelihood of all of the different parasomnias, sleepwalking, all of the parasomnias. Worsens memory and should never be mixed with any of the sleep aids. All right, so what about marijuana? Every talk nowadays has to include something about marijuana. You'll laugh, you'll cry, you'll go to sleep. It's the only known cure for damn near everything, not true. THC in small doses can reduce sleep. Can reduce sleep onset and increase total sleep time. It may increase slow wave sleep, but it reduces REM sleep. And too much can lead to hangover effects the next day. Withdrawal from chronic marijuana can be quite severe. It begins within 2 days and it worsens over the first 2 weeks. It's been documented that sleep disruptions from marijuana withdrawal can actually last up to 2 years in duration. It's a big topic of research now, but a lot more research is needed. All right, stimulus control. So patients with insomnia may come to associate their bedroom with fear of not sleeping. So they get in this bind of, I know I'm going to sleep, I just know I'm just going to lay there all night. And this can begin, with the end of their TV program, or if they look over and they see the clock says 11 o'clock, oh, it's time to go to bed. I'm in for another terrible night. And the longer they spend in bed trying to fall asleep, the worse the situation gets. So again, we want patients to go to bed at the same time every night or later. We want them to go to bed only when they feel sleepy. And an important distinction here is that sleepiness does not equal fatigue. So you'll talk to a lot of patients with insomnia and they'll say, oh, I get home from work and I just have to go lay down. Often they'll tell you, no, I don't fall asleep, but I just have to lay down, or I have to lay down for several hours every day. And that is different. That is fatigue versus sleepiness. Sleepiness is that sense that I'm going to go to sleep at any moment. It is not being fatigued. And this is a subtle difference, but it's important for patients to get that distinction, to separate those two. Don't go lie in bed if you're feeling fatigued, if you have insomnia. We want to, again, keep you out of bed, build up that sleep pressure. Furthermore, if you're in bed and unable to sleep, within about 20 minutes, to which the patient will say, well, you just told me not to look at the clock. How am I supposed to know? So I say if you're frustrated, if you're starting to get frustrated that you're not falling asleep, or about 20 minutes. Get out of bed and go do something quiet. Reading under a 60-watt bulb, very different than reading off of an electronic tablet with all that blue light. You might need to brainstorm with patients about activities that they can do, whether it's knitting or listening to a book on tape or something. Go back to bed when you feel drowsy and repeat this as necessary. So another thing is to wake up and get out of bed. So you can't just tell them wake up at the same time every day, because they'll wake up and then they'll lay there. So it's important to tell them not to linger in bed. So wake up and get out of bed so that immediately we're beginning to work on that process S, that buildup of adenosine. No naps, okay? Again, relieves that sleep pressure. And the bedroom is for sleep and intimacy only. We don't want to be eating in bed, watching TV, doing all these other activities. And the same rules apply on the weekends. We got to be consistent. 2 days on the weekend of screwing this up, and you'll be right back in the pattern the next week. Sleep restriction therapy, this is a very, very powerful tool, in my opinion. This is sort of the rubric that we use to employ sleep restriction. This is for patients that are spending too much time in bed. Okay, so you take a 2-week sleep diary. They might be spending 10 hours in bed and tell you they're only getting 4 hours of sleep. So what you want to do is restrict their time in bed to close to what they tell you they're getting. So in this case, if they're saying 4 hours, I'll go to 5 hours. We don't want to reduce them much less than that because it becomes a safety issue. And then you might add 30 minutes. If they say 5 hours, you might give them 5.5 hours just to settle down into bed and so forth. And then once they are sleeping approximately 85% of that restricted time, they get to increase the time by about 15 minutes to when they go to bed. They keep the wake-up time the same. No naps. And then it's contraindicated if they have a history of seizures because the imposed sleep deprivation early on might provoke this. Certain parasomnias or mania. You can set off episodes of mania with the sleep deprivation. Or if they need to drive, operate heavy equipment, and so forth. You always have to have that caveat of you need to be safe. So in this example, this patient was filling out the sleep diary, lots of time awake, little time asleep. I'll tell him, okay, based on that, give him the sleep diary. I actually highlight it and say, I don't want to see anything outside of the yellow areas. And then they come back. The first couple of nights are rough. You might get a phone call cursing you out around here. But eventually, if they stick with this, it can work very nicely. And for patients who tell you they go sometimes without sleeping at all, if it's safe and their schedule permits, I'll have them stay up the first 24 hours through the whole night and then begin this the next night. Relaxation therapy, so all sorts of techniques to help with relaxation. You tell patients that we really want to just facilitate an atmosphere that's conducive to sleep. We're not trying to force sleep with this relaxation. We're just trying to invite it. And there's a lot of online resources for all of these sorts of things. Cognitive therapy, I'm not going to go into this very much. This is sort of more in the domain of the behavioral therapists. They use all sorts of different techniques to help patients with their compulsions and worries about sleep, their racing mind, and so forth. But importantly, they're changing negative sleep thoughts and learning how to sleep without using medication. Online resources, so these are cognitive behavioral therapy from various online resources. The CBT-i was developed by the VA. It's free. It's an app. You can ask them to download this onto their phone. It has a lot of the components of cognitive behavioral therapy in it. Some of these others also have a lot of good data behind them. They do cost money, but it may be a lot more convenient and less expensive than a therapist. The pros, they're available. The cost, again, equally effective when compared to cognitive behavioral therapy from a therapist. Cons, less accountability. There's a much higher dropout rate as a result. And there might be a lack of recognition of comorbidities where that therapist might be able to see, the patient that might be suffering from depression, or maybe this patient has obstructive sleep apnea. So you may miss out on some of that. So in insomnia, we said one of the key things was not better explained by another sleep disorder. And so as a sleep doc, a lot of what I see in referral for insomnia is actually another type of sleep disorder, whether it's restless legs, sleep apnea, but a lot of circadian rhythm disorders as well. I'm not going to talk about jet lag or shift work sleep disorder. This is a good reference for those two things. I'll have it on a reference slide at the end as well. So this is a patient who says, I only sleep 4 hours per night. So they're going to bed, trying to do that consistent. I go to bed at the same time every night, but they're not falling asleep for hours, several hours, but they're consistently falling asleep around 1 a.m. On the weekends, they sleep brilliantly and then back to having difficulty again, relying on a lot of caffeine to keep them awake. So that patient has delayed sleep phase. So circadian rhythm disorders are characterized by sleep of normal quality and duration. So it's normal sleep, it's just not at a convenient time for the patient. And so they may come in complaining that they wake up too early in the advanced sleep phase, or I can't fall asleep until 2 in the morning with delayed sleep phase. A lot of teenagers have this. They're falling asleep at 2 in the morning, and then they got to get up for school, and so they're sleep deprived. They don't have insomnia because on the weekends, their parents are pissed because they're asleep until 2 in the afternoon. So delayed sleep phase, how do we treat this? We treat it with behavioral modification, gradual advance in the bedtime with a fixed rise time. You got to fix the rise time. That's very important. We'll treat with melatonin. It takes low doses, often at the lower end of this scale, 1 to 2 milligrams, 60 to 90 minutes before their desired sleep time. These next slides I spent a lot of time on. It was time not well spent. You're going to be wowed by the slides, though. So we're going to throw some melatonin in there, right? 60 to 90 minutes before bed. We're going to throw some light in there at their desired wake time, and we're going to push that sleep phase backwards here. That's fancy stuff. Hold your applause. Hold your applause. There's more. Another way to do this, other than melatonin and light, is actually to use chronotherapy. This is the idea that it's easier to fall asleep later than it is to fall asleep earlier, right? So I can stay up later. So in some patients whose work and schedule permits, we'll actually have them delay their sleep by 2 to 3 hours on successive nights, actually all the way through the day until they get back to when they want to fall asleep. And then we'll again use those light cues to cement that wake-up time. So this is chronotherapy. Advanced sleep phase. This is when, often noticed when a family goes to visit grandma and she's up in the middle of the night. And the patient will complain, I wake up too early and I can't fall back asleep. Well, that's because you slept a normal amount of time. You're not going to be able to fall back asleep. You're just waking up early because you went to bed at 6. So here again, we're going to use light therapy. Bright light therapy here at their usual bedtime is going to delay the sleep phase in this case and push them towards that normal sleep phase. And then again, using that light in the morning. Another big one, comorbid insomnia and sleep apnea. So we often lose track of this. The prevalence of insomnia in pre-diagnosed sleep apnea in primary care is about 34%. And in sleep clinic or in sleep clinics, sleep disorders clinics, up to 60% of patients have sleep apnea who are referred for insomnia. So a lot of times we're treating our patients for obstructive sleep apnea, and they're doing well, and they come back and they say, I'm wearing my CPAP, but I'm still sleepy. And what do we say? Well, wear the CPAP more. But we got to reevaluate. We got to back up and say, well, wait a second. They're doing well with that. Maybe they're doing all the right things for their sleep apnea. Maybe we're missing the insomnia. On the other hand, with the insomnia, the same thing applies. Maybe in treatment-resistant insomnia, the prevalence of obstructive sleep apnea in refractory patients is huge, 70 to 75%. Which begs the question, when do we get a sleep study for insomnia? We usually say insomnia is not an indication for a sleep study. Now, that's true during the initial assessment, but as I just told you, you refer the patient to us with difficult insomnia, we're going to get a sleep study. It's difficult to prescribe things like sleep restriction therapy to tell a patient, well, I want you to spend less time in bed if they might have sleep apnea that is disrupting what little sleep they do get. So we want to make sure that we're not missing that. And we got to think about also patients who might have central sleep apnea, heart failure patients, patients on narcotics, who might not otherwise look like typical sleep apnea patients. Also, periodic limb movements or other abnormal sleep behaviors. As I already said, refractory insomnia. Generally, we're going to get a sleep study on a patient before we turn that patient over to a behavioral psychologist to make sure that we've attended to any of the underlying issues. Certainly, I would think about a sleep study before committing a patient to long-term hypnotic therapy. And a home sleep test in the evaluation of insomnia is absolutely contraindicated. You don't want to take a patient that's already not sleeping well and send them for a home sleep test where you don't even know whether they're asleep or not during a home sleep test. An in-lab test will tell you when they're asleep and when they're not, and is the test of choice for evaluating a patient with insomnia. Sometimes sleep studies can be helpful for what we call paradoxical insomnia. This is patients who think that they wake up and look at the clock, they roll back over, they fall asleep, but then they wake up and look at the clock again, and they think they've been awake for the intervening 2 hours. Where you really suspect this, a sleep study that shows, yep, you slept the whole night, you only woke up a couple times, can actually be quite reassuring. There's also the reverse first night effect, which is in the sleep lab, the patient sleeps brilliantly. Maybe it's because they're taken out of their home environment where their snoring spouse or their pet or their TV or whatever else that's usually keeping them awake is not there. And this allows also for, an in-lab study also allows for observation of habits. I love to tell the story about the patient who brought a cooler with them to the sleep lab, took out a 6-pack of Pepsi, opened every can, and the sleep tech asked, you know, why do you do that? And they, well, I get thirsty, I get a dry mouth during the night, and they sip a 6-pack of Pepsi during the night. True story. What about guidelines for drug treatment of chronic insomnia? So the AASM says that all patients should receive cognitive behavioral therapy as primary intervention. That's a strong recommendation. Medication considered for patients, all the recommendations are weak for medication in insomnia. For patients unable to participate in CBT-i, that ought to be precious few, still have symptoms despite CBT-i, select cases as temporary adjunct to CBT-i. The British Association of Pharmacology agrees with all those recommendations and additionally says prolonged release melatonin might be first-line treatment in drugs for persons greater than 55. And the ACP says there's insufficient, they agree with these recommendations, but also say there's insufficient evidence for effectiveness of all benzodiazepines, melatonin, or trazodone in the treatment of insomnia. Drug studies for insomnia, largely they are run by the drug companies. Large randomized controlled trials with representative patient populations are lacking. Long-term outcomes are lacking. Only a couple studies have been longer than 12 weeks. Placebo effect accounted for 2/3 of the drug effect in a lot of studies. There was a meta-analysis comparing placebo to no treatment, which showed improved subjective sleep onset, total sleep time, and global sleep quality in placebo. And then these studies are plagued by a lot of differences in patient populations, the diagnostic inclusion criteria, what they called insomnia, how they evaluated responses, whether it was with questionnaires or sleep studies. There are almost no head-to-head trials looking at drugs, and there's tremendous publication bias. This is just to show you that the AASM clinical guideline drug data is weak. For every single recommendation, they say weak, weak, weak for all of the drugs. What about hypnotics and mortality? You got to be careful because I already told you insomnia probably doesn't kill patients, but the treatment with drugs probably does. A couple of studies to outline this, although the multiple studies have found increased mortality associated with hypnotics when looking at all-cause mortality. One longitudinal looking at electronic medical records in 10,000 patients receiving hypnotics. The hazard risk of death adjusted for confounders was, this is with 18 pills per year, less than 18 pills per year was 3.6. 18 to 132 was 4.4, and when you get up to a pill every other day, you're looking at a risk of 5.3 hazard risk of death. Retrospective cohort study of 34,000 patients, hazard risk for mortality was 3.3 in the first year after adjusting for confounders, and was greater than 2 for every subsequent year for a follow-up of close to 8 years. And there was a dose-response association for all the different classes of drugs, for benzos, non-benzos, and other drugs. There was a dose-response increase in mortality. FDA-approved hypnotics, here they are. Benzodiazepines, these are FDA approved, but I would draw your attention to these with the elimination half-life of 48 to 120 hours. Don't use this. Don't use these medications. So what about benzodiazepines? They target several of the GABA-A receptor subtypes. Down here you'll see the alpha-1 subunit mediates sedative and amnestic effects, while the other subunits mediate a lot of the anxiolytic, myorelaxant, the motor impairing, and alcohol potentiating effects. Benzodiazepines affect all of these. Okay, they're not selective. You want to avoid the long-acting ones, like I just alluded to, because of the accumulation of metabolites. Do they work? To some extent, but the question is are these clinically relevant improvements? 10 to 20 minute decrease in sleep latency, total sleep time. Most studies are closer to the 30-minute increase in total sleep time. They do decrease anxiety. There's rebound insomnia in 71% of these. And you got to be careful about these patients taking them and then stopping them, because dependence can occur in 20%. And there's an issue with tolerance. After 24 weeks, the sleep quality actually drops below baseline with patients on these drugs. Non-benzodiazepines, so they are more specific to the alpha 1 and 2 subtypes, so have fewer of those other effects, a little less anxiolytic and less anticonvulsant, but also less potentiation with alcohol, though still significant. Lower abuse potential as a result. Side effects, the antegrade amnesia. There's a reason these things are called sedative amnestics. Patients are probably just not remembering the awakenings that they're having in the middle of the night. They're probably still having them. In some cases, they may be having them more if their sleep apnea or other things are being exacerbated. They can exacerbate or unmask parasomnias, sleepwalking. Sleep driving is a big one, as you probably have heard about with zolpidem and others, because of that antegrade amnestic effect. You want to avoid these in the elderly, pregnant, nursing mothers, and liver disease. Melatonin antagonists, so ramelteon or Rozerem is one, binds melatonin receptors in the suprachiasmatic nucleus with a higher affinity than does melatonin itself. They're approved for sleep onset insomnia in the US. Interestingly, not approved in Europe. They just thought the data was not good enough to recommend this. Caused a decrease in sleep latency of 4 minutes and improved sleep quality, but no change in total sleep time. I mean, this is nothing. As I told you about before, placebo often does this. Fewer side effects than others. So it's great. It costs a lot. It's not very effective, but there are fewer side effects, so that's a good thing. You might consider this in elderly patients who are at risk for falls, is about it. Orexin receptor antagonists. Suvorexant or Belsomra. Orexin receptors in the hypothalamus promote wakefulness. These block that. They have a long half-life. Again, the decrease in sleep onset latency in studies, not tremendous. And cognitive behavioral therapy, the results are much better than these drugs. Side effects of somnolence, fatigue, abnormal dreams. Less common, sleepwalking, REM behavior sleep disorder, particularly in patients with Parkinson's disease. One key thing here may be that there's minimal respiratory depressant effect. So this might be a better option for patients with sleep apnea. Here, the 40 milligram dose, Belsomra is approved at the 20 milligram dose, but a 40 milligram dose caused minimal increase in obstructive sleep apnea in patients with mild to moderate obstructive sleep apnea. Increase the AHI by about 2 to 3. Again, I could have put this on every drug slide, industry-sponsored studies. Sedating antidepressants. Doxepine is really the only one that societies agree upon as being appropriate. In healthy adults this was a study looking at induced insomnia. A 6 milligram dose improved sleep onset, maintenance, and duration. A 12-week study of elderly patients with chronic insomnia showed that patients assessed by both sleep study and patient report showed no residual sedation or significant adverse effects. Clinically significant improvements in wake after sleep onset and total sleep time and sleep efficiency have been reported. Trazodone is not recommended for treatment of insomnia by the AASM. Now, that doesn't mean you can't use it in patients who have depression and insomnia, but if you're targeting insomnia, AASM says do not use trazodone. So here's a chart I put together of the FDA-approved drugs and then the drugs also recommended by the AASM and the ACP. So the ones that are highlighted here are all three. The ones that are not highlighted here, so these, in this case, these middle three here, if you can't really make out when I say highlighted, I guess I mean bolding. These three are not recommended by the ACP, but are recommended by the AASM. And then out here I have the cost that I found one day last week at Costco from GoodRx. So you can see the relative cost of a 30-day supply for each of these medications. So I would caution you out here, ramelteon, close to $400. There are better options. Take a look at the half-life of these drugs as well. Of these medications, azopiclone or Lunesta is also approved for sleep maintenance insomnia. And the data here, there's a lot of empty boxes, but this is the data when the AASM and ACP looked through studies. They looked through and they weeded out studies that they felt were not appropriate, and this is the only data that they had that they included in their summaries. So here for sleep maintenance insomnia, so again here you're going to see longer half-lives. Again, the costs out here. Suvorexant, Belsomra, $350 versus the other medications here. Importantly here, I have an asterisk here on the dosing. Always start at the lowest dose. Always start at the lowest dose. The AASM came out with in 2016 with a warning saying that the use of, particularly in the Nonbenzodiazepines receptor antagonists, always use the lowest dose. Melatonin, it's not recommended. Everybody uses it, so I made a slide. In dosage up to 10 milligrams, short-acting melatonin induced no significant effect on sleep architecture in healthy adults. Small effect on sleep latency on the order of about 10 minutes. In a double-blind, placebo-controlled trial in residents of a long-term care facility, 5 milligrams 1 hour before bed improves sleep quality and quality of life. That was the basis on which they made the recommendation that long-acting melatonin might be suitable for patients, older patients with insomnia. From, I believe it was the British Pharmacology Society. Food can delay absorption, useful in delayed sleep phase and in the circadian rhythm disorders. So again, not insomnia, circadian rhythm disorders. Does not produce tolerance, withdrawal, or rebound insomnia, and it's not recommended for treatment. Do I dissuade patients from using insomnia? If they're already using it, I don't, if they think it's helpful. When to use pharmacotherapy, the bottom line is rarely. Always provide CBT-i first. It's first-line therapy. Benzodiazepines, the risks certainly outweigh the benefits. Consider the nature of their sleep disturbance, whether they have sleep apnea or other comorbidities, whether they have depression, The half-life of the drug is important. The longer the half-life, you got to be careful about patients with drowsiness the next day. Side effects and cost. Use only the minimal effective dose. It's important to, when you're prescribing, to set out an appropriate duration. Talk to your patient about what is reasonable for the use of these medications before you find yourself in a long-term argument about chronic use. Talk about the risks of rebound insomnia with stopping. And consider intermittent use, maybe as long as 6 months for intermittent use. And consider a sleep specialist consult or sleep study before long-term treatment. Minimizing risk. We've already talked about a lot of these things. Avoid with alcohol. Importantly down here, when patients take these, you got to take it at the optimal sleep time. You got to go to bed with the intention of sleeping in 15 minutes. If you're taking this an hour before or 2 hours before you fall asleep, it's not working. I would get rid of it. Remain in bed for the full time required for the drug to be fully eliminated, and do not take the drug if there's insufficient time for drug elimination before planned rising time. So patients can't go to bed at 10 o'clock, wake up at 2 o'clock in the morning, and then take one of these long-acting medications. They're going to feel terrible in the morning, and it's going to be dangerous on the road. You've got to warn them about that. The key message here, avoid prescribing, there it is in the red box. Really, avoid prescribing these medications. As sleep docs, at least my colleagues and I at the Oregon Clinic, we very rarely pull out the prescription pad. That's because we write them all online. No, we don't prescribe sleep medications very much at all. It is the very rare case. Precautions with hypnotics. They can cause residual daytime sleepiness, worsen sleep apnea. They can cause a lot of complex sleep-related behaviors. They can exacerbate a lot of parasomnias. We've talked about a lot of these other cautions. Nighttime decision-making is a big one. Patients, with families, with small kids who might have to wake up in the middle of the night and care for them. What about physicians answering the call in the middle of the night? Older adults, you got to worry about falls, delirium, medication interactions, and use with alcohol. Always ask about this because the combination can literally be deadly. When to refer? Suspicion of an underlying sleep or psychiatric or neurodiagnosis. You might want to think about referral to a psychiatrist or neurologist. Poor response to behavioral interventions or drug therapy. I would say even before, a strong thought about it before even considering drug therapy. Insomnia associated with a parasomnia is certainly an indication for referral. Who do you choose? Maybe you're not sure of the diagnosis. You can send them to the sleep medicine docs. Or if you think they may have a suspected sleep disordered breathing or parasomnia. If you think there's a lot of comorbid depression or complex pharmacology that you're having difficulty managing, maybe think about a psychiatrist or other neurologic disorders, as I've said, neurologist, behavioral psychologist for the cognitive behavioral therapy for the hardcore insomniac that is not responding to other therapies. And when you make that referral, please, you might ask who you're referring to, do you want a sleep diary? You might ask your patient to start filling out a 2-week sleep diary. So in conclusion, you want to assess and manage comorbidities and medications. You want to consider those alternative sleep disorders before concluding that it is insomnia. CBT-i is first-line therapy. Review sleep hygiene to reverse some of those dysfunctional sleep habits and substance use. Use a sleep diary, not only to tell you what's going on initially, but also it's helpful feedback for the patient as you through therapy that they can see that progress. And then 4 rules here. Reduce the time in bed to the time that they're actually sleeping to increase that homeostatic sleep pressure. We want to establish consistent wake times to really hone in on that circadian timing and get those 2 processes working in synchrony. You want to go to bed when you're sleepy to make use of that homeostatic sleep pressure. And you'll want to get out of bed if you're not sleeping to work on the stimulus control. Pharmacologic therapy, second line or not at all, preferably, and only short term. So here's some resources, some books and the online resources. This was that reference that I thought was really good, pretty good deep dive on how to manage your jet lag if you're planning travel, how to use melatonin and light so that you're pushing or pulling your sleep in the right direction. And then this is the AASM guideline on the pharmacologic treatment of insomnia. You're always welcome to give me an email if you have other specific questions. Ooh, I went way over. I apologize. Yeah.
How effective is it?
Yeah.
And can you use the opposite for light therapy?
Yeah, good question. So the question was about the dim light setting that removes blue light from your tablet. Most of them have that setting. And can you use the tablet on the regular setting for light therapy? So the tablets are a problem even with that setting because there's that interaction with the tablet, right? So the light in general is still a problem. It's still brighter than the reflected light off a page. And it's that interaction with the tablet that is further a problem. So I would prefer that they set that aside entirely. It's better with that setting, absolutely. Does it work as light therapy? No. The light is not bright enough for that. Light boxes actually are really, really bright. We usually recommend about a 10,000 lux light box. Those can be a little spendy. I found them on Amazon for somewhere in the range of 45 to 100 bucks. Also, when you're looking at light boxes, you got to pay attention to the recommended distance from the patient because that 10,000 lux is very dependent on how close they are. And a lot of the smaller ones have to be in your face, literally, to be effective. Oh, up here we had a question, yeah. Yep.
And why the AASM does not recommend it is because it hasn't been studied well.
Yeah.
And then the other thing is, when they looked at the mortality with hypnotics, did they look at causes of death?
It was all-cause mortality. It was compared to a cohort of controls. So the question was about all-cause mortality. Did they look at cause of death? It was all-cause mortality, and they did have a control cohort. And the other question was about melatonin. So I mentioned melatonin a lot, and then I said don't use it. Use it for the circadian rhythm disorders. It is effective in those instances at low doses. Why does the AASM not recommend it? It's because the studies are not suggestive that it makes a clinical difference. So we want to be prescribing medications based on what works. And it was, in their opinion, and if you review the literature, for use for promoting sleep, it is not robust at all. I don't think it's harmful in the way that the other hypnotics are. Dr. Gilbert?
Hi, Bill. That was great. I suspect a lot of the patients come in and ask you about the over-the-counter sleep aids that have the sedating antihistamines. What do you tell them?
Yeah, I tell them that the sedating antihistamines have a lot of other side effects. So there's more the effects of sedating antihistamines on sleep. There's more literature coming out about associations with depression, with dementia, with chronic use. Took my Benadryl last night. There's also a lot of daytime hangover with those medications. So no, in general, I dissuade them from the use of those. The other thing is that it evokes a lot of parasomnias and fragmentation of sleep with the antihistamines. So I think the studies have been looking at large populations using a broad spectrum of medications, including those. So not looking at individual medications and identifying. And I think it's important to make the distinction between association and causation as well. So these were associated, and if I misspoke on that, I apologize, but we want to, they are associated with increased mortality, not necessarily a cause of that. So there aren't specific studies suggesting that any one of those specific medications increases mortality. As a group, all of the sedating hypnotics seem to be associated with an increased mortality. I'm not sure that that is a sufficient answer to your question, but that's the answer.
My question is, if the sleep aids are actually not that effective, why are patients so attached to them? And
So attached to?
To sleep aids. It's
Yeah.
so hard to get people off of them and convince them that this isn't the answer.
Yeah, so again, they're called amnestics, sedative amnestics, for a reason. You know, they're sleeping through a lot of their awakenings in the middle of the night. It's not that they're not having them, they're just not remembering it. It changes their perception to some extent of their sleep. And for a lot of people with insomnia, they get so worried about their perceived quality of sleep, and that becomes a big focus for them the next day. And they feel that that's the only thing that, you know, with the placebo effect and everything else, it may have worked for a short time for them. And then they buy into that and feel like, okay, I finally got a little bit of what I perceive to be better sleep, even though it may not in actuality in studies have been so. And then, yeah, getting them to give them up is hard. We all share that frustration. Good question.
It probably seems too simple, but has anyone done any studies on the quality of the bed?
Quality of the bed. Yeah. Is that the? Yeah. Sure. The Sleep Number folks would love to talk to you about that. So the question was about the quality of the bed. Yeah, there have been studies looking at different beds, different types of pillows, the alignment of the neck on the pillow in improving these things as well. And some of that goes into sleep hygiene and could be grouped into the bedroom environment has to be dark, quiet, and comfortable. So you can pull that into the comfort thing when you're drilling down and asking questions about the sleep environment. All of that is inherent to that. It's a good question, but I'm not aware of specific studies, but I'll bet you the mattress makers would have them. Yeah.
Does postprandial sleepiness have anything to do with nighttime sleep?
Does postprandial sleepiness have anything to do with nighttime sleep? Well, indeed, the curves as depicted on those initial graphs were a little simplistic. There is a circadian dip in the afternoon. We call it postprandial. It's there whether you eat or not. It's not so much due to the meal so much as the timing, the Zeitgeber of the meal, if you will. Giving into that, yes, can affect sleep, and it may be the reason why, if you've done any traveling in Europe, that places where they have siestas are eating dinner at 9 o'clock at night and going to bed much later, because they're getting the same amount of sleep in 24 hours, but they're getting some of that sleep in the afternoon. And specifically when you're dealing with patients with insomnia who, by definition, are having trouble sleeping, you really want to dissuade them from that nap and try to fold that time into their time at night to consolidate it and get deeper, more consolidated sleep at night. Anything else? All right. Thank you.